Greetings, Sanbonani Absheni. Welcome to my YouTube channel. So in today's video, we'll be going through gestational hypertension and chronic hypertension. Obviously, in the previous video, if you haven't watched the previous video, it's a sign to go back and go watch it. But I did define the difference between these different hypertensive disorders and how they are diagnosed in terms of their definition themselves. So it is quite easy. If you understand the definitions, then it will be easy for you to classify a woman as either having chronic hypertension, gestational hypertension, pre-eclampsia, imminent eclampsia, and all of the definitions that we went through. But today we are going to be talking about the management of chronic hypertension and gestational hypertension. So as you can see, I had already said chronic hypertension versus gestational hypertension, but then here's the news flash that they are actually managed the same way, even though they are two different things, because the chronic is a condition that was already there even without the pregnancy, and the gestational is a condition that is induced by the pregnancy itself. They're actually managed the same way because at the end of the day, they are hypertension. So with chronic, what is important to note is that because now the woman is pregnant, you're no longer gonna treat the chronic hypertension as you treated it before she was pregnant, meaning that her treatment is going to change, and there are other factors that we should consider as we are treating this woman, as this woman is having antenatal visits. There are things that we have to put in mind, and there are things that we must inform the woman about, because now it is no longer about her health, but the health of the baby as well. And then with gestational hypertension, we then obviously that nothing changes because the woman probably wasn't on any treatment already. Let's say it's given that she wasn't on any treatment, so now you just have to cancel her, to change her lifestyle, help her to understand that she can't eat certain things anymore, that she'll have to put this into her routine and do that. And so in today's video we'll be explaining that. As I did say, they are managed the same way. So everything that I'll be mentioning, the management will apply to both chronic and gestational hypertension. I hope that makes sense. Let's get into the lesson. So let us get right into it. The management of chronic hypertension in pregnancy and gestational hypertension. As I did mention, the management will be the same for both of these conditions. So firstly, it is important for us as healthcare workers to give advice to every woman that comes into our facility, especially if she has a condition that can be very risky or very dangerous for her pregnancy, such as hypertension. Firstly, we will educate her about her nutrition to maintain a low salt diet. Salt contains the component sodium, which can potentially cause fluid retention, and fluid retention will then result in a blood pressure that is more elevated than it is. We must also educate her on weight monitoring. Obviously, her eating habits will change with pregnancy, but she must try to maintain healthy eating habits that will not make her gain too much weight, because with weight gain, that will also be a factor that increases her blood pressure. Secondly, bed rest. So with hypertension, we need to avoid strenuous activities, or rather engage in light duties, because strenuous activities can or have the potential to increase your blood pressure to be more elevated than it already is. Number 3, if she has chronic hypertension, it means that she was already on some sort of antihypertensive treatment. But with antihypertensive treatments, most of them give the risk of the baby having congenital malformations, because they do have components in them that are not healthy for the growing fetus. So we will stop the antihypertensive treatment and then start with methyl dopa. And then fourthly, we will advise the woman to monitor her blood pressure at home, show her what the normal ranges for her are, and advise her that if there are any abnormalities in her blood pressure, she needs to go to her antenatal clinic as soon as possible. Okay, number 5. We advise the woman to monitor the fetal movements. So I know in most healthcare facilities, we will give the woman a chart where she can monitor the baby's movements, the baby's kicks in a certain hour when she is not busy. And then this also helps her to regularly see if the fetus is growing well and if the movements are well and if there are no changes in the fetal movement. Remember that as a healthcare worker, it is important to note that hypertension forms the risk of intrauterine death and intrauterine growth restriction because hypertension does narrow the blood vessels, and this means that there is limited blood flow to the growing fetus itself. And so hence why these babies will then have the risk of intrauterine growth restriction or worse, intrauterine death. So the woman has to monitor the number of kicks and monitor if the kicks are decreasing or increasing. Remember that we want them to increase as the baby grows because that is positive for us. Number 6, we need to emphasize that the woman must go to prenatal visits for her next pregnancy. Remember, this is important that her blood pressure is monitored before she plans to have another child. We need to monitor her blood pressure and make sure that it is within controllable ranges. Okay, now let us get into the antenatal care of a woman with chronic hypertension and gestational hypertension. Remember that these conditions are normally managed at district or tertiary level. They might be diagnosed at a community clinic, and then the woman has to be referred to a district or tertiary level hospital. It is important that lab investigations are performed. These are like your full blood count blood tests in order to assess if there may be any other factors that can worsen the hypertension. We need to also collect a 24-hour urine sample. This helps us to trace the protein and the creatinine and other factors that may indicate the severity of the hypertension. We need also to perform a glucose tolerance test. This is important because usually with women who have hypertensive disorders, they are more prone into also having gestational diabetes. Remember that these two usually go hand in hand. And so we need to screen her for diabetes as well. Hence, we will perform the glucose tolerance test. Then we also have to assess and manage coexisting conditions, not only treat the hypertension, but also treat other coexisting conditions because they can also worsen the hypertension. If the blood pressure is uncontrolled, usually pregnancy is induced at 37 weeks. What I mean about induced, it means that we will have a medical way of making sure that the woman goes into labor. This is sometimes done even earlier than 37 weeks, especially if the blood pressure is uncontrolled. If the blood pressure is controlled, we normally allow labor to progress as it normally would. Let's go into the intrapartum and postpartum care of a woman with chronic hypertension and gestational hypertension. So during labor, it is important that we monitor her blood pressure, especially if it was uncontrollable during the antenatal period. It is important that we also monitor the fetus continually because if the blood pressure was uncontrollable, then it really puts the fetus at risk for intrauterine death or the baby being born as a already demised. So it is important that we do monitor the fetus. As I said, before we allow labor to progress normally is if everything is within control. Now, note that I know here I'm writing something completely different, but note that with women with chronic hypertension and gestational hypertension, we do advise the use of oxytocin for the management of third stage of labor, because the opposite is true. With your ergomatrin or symptomatrin, it has an effect of prolonged vasoconstriction. Remember that we give oxytocin or ergomatrin so that we prevent postpartum hemorrhage. But with women who have hypertension, we will give oxytocin because it has less of an effect of prolonging vasoconstriction than these other agents. We need to monitor the blood pressure postpartum, and also remember that postpartumly, we then also change the treatment of the woman. If she was on her chronic antihypertensive medication, she goes back to her chronic. And if she was gestational, usually the high blood pressure will resolve itself, and then we will stop the treatment. Thank you so much for watching. I hope you enjoyed the video. Please like, share, comment, subscribe, and the resources are in the description box. Thank you.